You how pleased I am and happy I am to be here. I came here thinking it was here at St. Vincent's East, and then I've walked around and people said, there's no auditorium, you're talking about the Bruno Center downtown. And I almost drove to the Bruno Center, but then I found you all. So I'm happy to be here. I first always try to get a sense of the audience. I mean, I know that there's a wide variety of disciplines here. Who are pharmacists? Great, I love it. And who are social worky kind of people? Who are physicians? Who am I forgetting? Clinical nurse practitioners. Excellent. Who have I left out?
PAs.
Who?
PAs.
Oh, wonderful. Okay. Now, one thing to start the talk off with is that I am hard of hearing. I do wear hearing aids, which is great, except my phone died on me last week, and it was Bluetooth to that phone. It's not Bluetooth to the new phone, so I can't turn it up or down. And just this morning, my right hearing aid started to kind of phase out. So if we get to a question and you ask me a question and I look blank, like I haven't heard you, it's because I haven't heard you. So wave your hand and I can come to you and we can, it'll take me out of the visual field, but at least I can hear what your question is. They asked me a month or so ago to talk about mental disorders and medication, and I'd prefer to call it mental illness because one of my lifetime prerogatives is to try and decrease stigma related to mental illness. So let's just call it what it is. It's mental illness. The next slide, if I can get me to it, is kind of talks about my background. So you can have a sense of what life experiences I bring and the degree of perhaps scholarly nature that I can bring to this. Right now I'm a professor emerita at UAB, which means I served my time. I was 27 years working at UAB. I trained at the University of Texas at Austin, where I was working on behavior genetics, actually, and then I got into medical school at UT Houston. I did my residency at Duke. I was on faculty Duke for 3 or 4 years and then decided to move even deeper south and came here to Birmingham and have been here since. I'm editor-in-chief of a community mental health journal. Community mental health has been my soul and heart's passion for the last 25 years. I also work with NAMI, which is the National Alliance on Mental Illness, and I'm their associate medical director. And I assumed that when I ostensibly retired from UAB. And I say ostensibly because I spent 2 hours in the office this morning. I have an office in the chairman's office. I'm like a substitute teacher now. When somebody wants to go on vacation, from the inpatient unit, I can just go, sure, I'll be glad to do it. I had a friend who wanted to go to India, and you never go to India for just the weekend. So I covered his service for 5 weeks. And that way I get to keep my hand in on the newer medications. I get to work with a lot of the patients for whom I provided care for 25 years. I get to teach the medical students and residents. So retirement's the best gig in the world, I'm telling you. If you can afford it, take it early. In my past life, you can see that I've worked for providing consultation for a lot of different agencies. I worked with the Alabama Department of Corrections. We used to have what was called the Medical Advisory Committee, where every 2 months we would visit different prisons around the state, which is unbelievably eye-opening, and I only want to underscore, please don't perpetrate a felony in Alabama, because it's a rough life. Imagine wearing a heavy cotton tweed one-piece uniform for your days in prison that are not air-conditioned. The only places air-conditioned are the administrative buildings, death row, and administrative SAG. So unless you're in really bad trouble, you're going to live in a 100-person dorm with no privacy at the commodes or the showers, and it's a miserable existence. It's terrible. But we provided, my role was to kind of look at the mental health services that were provided and also to comment on the medical services that were provided at each one of the prisons. And this was in support of a federal decree because as you know, nothing happens in Alabama without a federal decree. We are the make me state. I was a federal court monitor for Tutwiler, which means every 2 months I went to Tutwiler over a 5-year period to see if they were following the federal decree. That was very, very eye-opening. Since I left probably 7 or 8 years ago, they have now gotten themselves back in some trouble, and you will just continue to see that. And you're all healthcare providers. You know we have certain standards and certain ethics and morals, and I don't mean to besmirch our colleagues who work in the prison system because it's very hard work. I don't think there's many bad eggs there. I think they're just under-resourced, understaffed. I did work with the Department of Justice, going into the state hospitals over in Georgia, and my only solace is comparing it to the state hospitals here in Alabama. They're even worse, and they continue to struggle, as do we. But my life's blood has been working as the medical director and executive director of the Community Mental Health Center at UAB. Lots of patients living with serious mental illness, and we work to provide whatever services we can for them. I've done some research, you can see that. I'm also part and parcel with the American Association of Community Psychiatrists. There are those of us who work for those who live in communities, and communities can be defined by if you're homeless, if you live in a condo, if you live in a prison. I mean, we all have our communities, and so we go wherever people go. And that's going to be linked into kind of when I'm talking about medication and adherence. All right, but before I start, I always like to start with a quiz. The reason I wanted to start with a quiz is because it helps get us thinking about not just adherence or compliance and medication, but kind of our expectations about adherence and how we react to that. And that it's not just, here's a pill, you take it, you get better, and bye-bye. It's never like that, and you all know that. I'm really preaching to the choir here. How many of you take all of your medications as prescribed each and every day? Fantastic. The majority of you did not raise your hand. I can't raise my hand to that either, and I'm actually going to tell my personal story in just a minute. And we're all high-functioning, intelligent people who know that we should be taking all of our medications as prescribed every day. And yet, we aren't. Most of us are not. Good for you guys who are doing it. So I want us to mold that into our thinking about adherence, because if we aren't able to do it, imagine what it's like for people who are struggling with all of the issues concomitant with mental illness. How many of you complete an entire course of antibiotics? Good, okay, and that's good, and that's probably easier to do because it's short term. 3 days for a Z-Pak, 10 days for a thus and so for a UTI, et cetera, et cetera, et cetera. Those are easier to do, but the illnesses that I'm going to be talking about are not acute illnesses, ever. These are illnesses that last basically forever. I'm a firm believer in recovery, but recovery is in the eye of the beholder. So these are illnesses that last a long time and complicate people's lives. And we don't have to raise our hands on this, but it's just to get you thinking about when I ask my patient who's living with schizophrenia to take a certain medication, I'm not just asking him or her to take it for the next 3 weeks or 3 months or 3 years. I'm probably talking ad infinitum. My first patient that I saw at UAB, his name was Tommy, and Tommy came up to me and said, "Who you for, Dr. Feldman?" And I came from Duke, where, you know, we don't talk about football, all we talk about is basketball. And I said, "Well, gosh, Tommy, I don't know." And he goes, "No, who you for? That's really important to me." And Tommy had, not, in addition to schizophrenia, a frontal lobe injury, so he was like this close to me, which was fine. And I said, "Well," and he had on an Alabama t-shirt, and I said, "Well, Tommy, I'm for Alabama. And so he literally picked me up and twirled me around and said, we're going to get along fine. Now, the second question he asked me was, how long you here for? Because a lot of people who work within the context of mental health see different providers at each visit. And I don't like that. If I got upset when I delivered my second baby and I had to say goodbye to my OBGYN. It was like, wait, you've been such an important part and I've known you for 9 months and you're leaving me. And she looked at me like, what are you talking about? But it's that, we get attached to our providers and it throws people off when they lose that provider or the provider is inconsistent. So I'm going to talk about some of those issues in terms of how we can help people remain adherent. But how many of you would take a lifetime medication that dries your mouth, causes excruciating muscle cramps like EPS or pistotonus or ocular gyrate crisis where your eyes roll back into your head and you can't get them back down, or that causes significant weight gain? Or it may cause a fatal skin condition, like you get with Lamictal or lamotrigine, or a granulocytosis that you might get from clozapine, or something that affects your nature. Now here in the South, I never have to explain the nature, but when I give talks up north, they're like, what are you talking about? I challenge us. How many of us would take a medication for the rest of our lives that would affect the one area of functioning that gives us pleasure? That continues to give us pleasure. So those are all the things we have to think about. We are just like our patients. These are the concerns that they have, and they may or may not talk about them, and so we always have to give them opportunities to speak about. All right, how do we define adherence? I mean, it's not rocket science. The World Health Organization said, it's the extent to which a person's behavior, taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendation from a healthcare provider. The important word there is agreed recommendation, because we can talk till we're red or blue in the face with our patients. If they don't agree with why they're taking it or how they're taking it, or understand the side effect profile, or that right there is the beginning of pushing them towards deciding not to take their medication. For our purposes today, somewhat, it's accurately and adequately taking medications at the correct time, the correct dose, and in the case of the patients with whom I work, for prolonged periods of time. It's important, I keep drawing us in because it's important for us to, one, have walked in the footsteps of our patients, but two, it's also important for us to understand what in the psychiatric parlance is countertransference. And countertransference are those unconscious feelings that get elicited by something that our patients do. And our role as healthcare providers is to make that which is unconscious conscious. So like when I round on an inpatient unit, I have patients that are very difficult, that are very challenging, symptomatically, or they're challenging the treatment plan, and I say, within the context of rounds without the patient in the room, I say, let's talk about our feelings about this patient so that we don't act out on those feelings. Because sometimes patients elicit not just happiness and joy at their progress, but frustration and anger and et cetera, et cetera. So we need to be mindful of that so we don't act on those. None of you would do that, but and hopefully I wouldn't do that, but it's important that you recognize that those feelings are there. And when patients are non-adherent, that can elicit, I'm probably projecting, a lot of frustration. It's like, but we talked about this, and now you're coming back and telling me you haven't taken your medicines, or you're taking it inconsistently, and you're having symptoms, and I'm trying to help you, and you can kind of spiral down from there. So you need to try and identify those feelings that you yourself are having. All right, but let's look at adherence rates. Poor adherence is the norm across all chronic disease states. It's not just mental illness. Anxiety, this is from Errett and Wang, was a nice article in the Mental Health Clinician. Anxiety, 57%. Unless, of course, they're taking benzodiazepines, and then they're probably 120% compliant. Major depression, 28 to 52%. Bipolar disorder, 20 to 50%. Schizophrenia, 20 to 72%. But then you look at things like breast cancer. You'd think, oh, of course somebody is going to be compliant with the entire treatment regimen. Studies have shown 50 to 100% adherence. Good if it's 100%, not so good if it's 50%. Diabetes, 50% are capable or choose to make the lifestyle changes. In terms of being compliant with medication, 53 to 67%. Daily checking of blood glucose is only 5% if you're on an oral medication. Time for me to fess up. I have asthma. For many, many years I've had asthma. And for the pharmacists in the room, when I tell you what I'm on, you're just going to shriek. I'm on theophylline, which is, I just came back from vacation in Colorado, and I had to get some refills while I was out there, and they're like, theophylline? Wait, I don't even know if we have that anymore. But it works, and it's cheap, except it's written for 3 times a day, and I take all 3 at night. So even there, I'm non-adherent. But it doesn't keep me up, which is amazing, because it's kind of caffeine-oid-like. I also have hypertension. I'm pretty good with my antihypertensives. Not so good with the lifestyle changes until about 6 months ago. And I have diabetes. Now, I don't think I'm being narcissistic. I'm pretty smart. I kind of know what I'm supposed to do. And my primary care doctor, remarkably tolerant of my non-adherence. Well, you know, how high do you let one's hemoglobin A1C go before you really start shrieking at a patient? Now, the good news for me is I had an epiphany in February and said, this is ridiculous. I also turned 65 in December, and so that meant I got silver sneakers, which is a wonderful program, and it pays for my going to a gym, so I get the gym for free, and I now exercise 2 hours a day, 7 days a week. And I've lost 32 pounds. My hemoglobin A1C is 5.2. I've gotten off of one of my diabetic medicines. My blood pressure is the best it's been in 20 years. But you know, I'm kind of a smart person. Why did it take until I'm 65? I mean, I could certainly have afforded a gym prior to being 65, and I paid for a gym. I just didn't go to the gym. So the lessons I'm learning about me and the strange ideas and denial and excuses that one makes for one's non-adherence has been very instructive for me and help me deal with my frustration when I'm dealing with people whose lives, particularly the people with schizophrenia, whose lives are profoundly chaotic and disorganized and unstructured and often unsupported. So it's really, it's been helpful for me. But none of us, except for the 4 of y'all, are adherent as we should be, and we need to figure out why that is. And I'm going to talk about some of the things we can do logistically, but there are other things we can do in terms of our relationship with our patients that hopefully will be helpful. All right, so there are correlates of non-adherence in patients who are living with mental health issues. Often they're more young, unmarried, male, less educated, may have troubles with visual acuity or literacy. I mean, what good is it to hand a patient a bottle if they can't read it? Hopefully they're living with somebody who can read it, but I got to the point where I would take pictures and say, you need to take these this time and these this time. You know, how often have you taken a history and the patient will say, well, doc, I take 3 white ones. Now, one's round and one's oval. And I'm like, well, do you remember the names of them? Well, no, but and so it's that kind of thing. So I gave patients that sheet so they could fold it up and carry it in their wallet. So if they had to go to the emergency room or go see a primary doctor, they're at least able to communicate that information. If somebody's using substance, alcohol, cocaine, marijuana, you name it, we've got it here in the state. You need to know that because sometimes that impairs people's judgment, capacity to take medicine in a regular fashion. You certainly always want to ask if they're smoking and see if you can help them stop smoking. But smoking can increase the metabolism of some of the medications. I'm going to talk about that a little bit later. Poor insight. Anosognosia. I love that word. I can't pronounce it, but I love that word because it really reflects the poor insight some people have into their illness. I have a lot of patients who have schizophrenia who say, I do not have schizophrenia. I don't care what you say. And the point is, if somebody believes they don't have an illness, bless you, if they believe the problem is the rest of the world and not them, how likely are they to take medicines, particularly if they're medicines that are prone to really kind of awful side effects? Not very likely. So it's a constant tension. Doesn't have to be bad tension with your patients. Sometimes there are families who deny that their son or daughter or husband or wife has a mental illness, and they're like, no, it's not a problem. They don't have it. Things were a little rough, but they're better. And so it's not just the patient you're working with the family as well. And there's also a lack of conviction that's possibly based in reality that they don't believe that the medications can prevent a relapse. And part of the problem of the nature, certainly of serious mental illness, is that sometimes patients can be adherent and the illness still comes back. So it's kind of like, that's kind of negative reinforcement. Doc, I swear I was taking my medicines and now the voices are back really bad and I want to kill myself. And I mean, you always have to go, well, are they really taking it? What do I need to do? That kind of thing. The issue here is that, sometimes you'll have patients who will show up and they're symptomatic. And you're like, oh gosh, I need to increase the medication. And the question you should be asking is, help me understand, how are you taking this medication? Oh, well, it wasn't helping me, so I stopped it 3 weeks ago. And helping them perhaps make the connection that stopping the medication 3 weeks ago when it wasn't doing anything, and now they're presenting to you grossly psychotic, it's the beginning of a conversation. But I know in our haste and in our very busy schedules, we might prescribe things, increase prescriptions, when really the question we should be asking is are you taking the medication? This is kind of a densely packed slide, but I'm going to work my way through it because I think they're obviously important. There are medication-related correlates to non-adherence. And I keep using the word adherence and not compliance, because compliance means I tell you to do something and you take it. And non-adherence really starts to begin that process of our buying into the concept that patients choose to adhere. So this really is starting to get into the issue of patient choice, of discussing with patients. It's what's called the shared responsibility model. I'm going to talk more about that later. Side effects. There are some really awful side effects to the medications that I prescribe. I mean, there are medications that affect a patient's nature. There are patients who will say, well, I'm allergic to that Haldol. And I said, well, what do you mean you're allergic to that haloperidol? And they say, well, my eyes roll back and I get real stiff. Well, we know that's not an allergy. That's an extrapyramidal symptom that can be acutely painful. Chronically, what if somebody gets akathisia from first-generation antipsychotic, and whether or not it's considered an allergy or a side effect, they can make patients miserable. And I have seen colleagues, I've seen residents say, well, they'll go away, or they're not really a problem. Well, unless you've experienced akathisia, I have a close friend who's allergic to Reglan and gets terrible akathisia when he takes Reglan. And he goes, oh my gosh, I didn't understand akathisia, and he's a psychiatrist, until I took this, and it's terrible and it's awful. So we're asking our patients to take these medicines for a long time in the face of side effects. So one, you have to acknowledge the side effect. Perhaps you can prepare them for the side effect. Now, I have had patients who say, will you copy the PDR side effect list? And I'm always a little wary to do that because that, I don't want to say that it causes patients to imagine they have it, but it puts them on guard for searching for things that perhaps it's not really a side effect, but they go, but it was on the list. So you want to perhaps give them a heads up, perhaps prophylactically say if you get EPS, explaining what EPS is, you might give them benztropine, that kind of thing. If you start to get a bit stiff, if you start to get a bit whatever, you might try this. Please call me if you start to have side effects so we can discuss it. Don't just stop your medicine. All those things you want to continue to reinforce with your patients, which gets us back to one of the things I talked about before, which is if you're seeing a different provider each time you go to the clinic, that's really hard. One, you haven't established a trusting relationship, and two, I don't know why that Dr. Smith prescribed that. That's not a good medicine. Or, don't worry about those side effects. I mean, you've got to have that trusting relationship going on. And you have to, how you respond to a patient's reporting of a side effect is going to impact not just that momentary interaction, but the interaction for the rest of the relationship. If you say, don't worry about it, it's nothing, that's denigrating their stance and where they are and where they are going. And that immediately affects that relationship. It's, she didn't listen to me. I'm leaving with not only the same medication, but she increased the prescription. She's not hearing me. So I'm going to talk about some of the ways we might want to deal with that. Metabolism, again, smoking can induce metabolism of imipramine, haloperidol, and clozapine. So what's really interesting is, now the hospitals are non-smoking, I've got patients that I start on clozapine, I get them up to a good level, and they look really good, and then they leave and get back to smoking 3 packs a day, and they come in grossly psychotic. You just have to, that has to be part of the equation. Now, I think we as healthcare providers need to be much more vigorous in our smoking cessation efforts. I know it's hard because it takes time. It takes will, it takes determination from the woman who didn't start exercising until 6 months ago. But it's something that you constantly have to be thinking about. And it's hard. I mean, a lot of my patients with mental illness really are 3-pack-a-dayers. I mean, they light one cigarette to another, to another, to another, which makes going in the hospital really, really hard for them. People who are pharmacy people certainly understand the more you can simplify the dosing, the more you're going to ensure adherence or better adherence. Like my theophylline, 3 times a day? 3 times? Who can remember to take a medicine 3 times a day? Unless you've got an alarm on your Fitbit or something like that. The more times you can pull together medicines safely, the better. The issues of taking medicines by mouth. In terms of psychiatry, instead of IM preparations, I'm not talking about the acute ones that you give, the ziprasidone in the emergency room, but I'm talking about the ones you can give every 2 weeks, every 4 weeks, every month, every 3 months. That's kind of become the dream of us, but the issue of adherence still comes in. They still have to come to the clinic to get it, unless you can get creative and start working with pharmacies that they live close to and they agree to give the shot, et cetera, et cetera. Cost is a huge conundrum, particularly for the patients with whom I work. If you ask a patient who's got Medicaid to pay a $3 copay for medicine or buy a pack of cigarettes, I'm telling you, it's going to go like this. So you have to be thoughtful about it. What can you write for? Can you get a patient enrolled in a pharma patient assistance program? At the UAB Mental Health Center, we have a person full-time, dedicated. That's all he does, is enroll patients in pharma patient assistance programs. Per not a statute, but it was imposed by our dean many, many years ago. They said no more samples. I mean, we were probably giving out about $500,000 worth of samples every year to transition people, to bridge them. But we work really closely with pharma patient assistance programs, and I know there's philosophical conflicts about that. But if I've got somebody who ain't got no money and they need a certain medicine, I'm going to err on the side of getting care for my patient. Efficacy, how quickly and completely does it work? I used to run a pre- and postpartum depression clinic with the OB Comp Clinic, and I would see patients, I would see women. When we developed it, we thought we were going to see most people who were postnatal. No, most of our patients were actually prenatal, very depressed, and you have to go through all the informed consent, et cetera, and with antidepressants, they take time to kick in, with the exception perhaps of ketamine, which I'm not going to talk about today, because ketamine wasn't on the market so many years ago. But I would explain to women time and time and time again, this medicine takes a while to kick in. Now the challenge, when you're depressed, now I've been fortunate, I've never suffered from depression, but I've had family members who have, and who get desperate, and you feel really bad. I mean, we're not just talking, oh, I woke up, I was sad. I mean, we're talking, I can't even get out of bed. We're talking 10 crying jags a day. We're talking feeling suicidal. We're talking, I can't think in an organized fashion. I can't sleep. I have no energy. I've got to take care of my kids. What am I going to do? By the time people kind of say, I'm depressed, I need help, it's really hard to say, oh, I've got a good medication for you, but it's going to take 4 to 6 to 12 weeks to kick in. That's really hard. And it's something we got to deal with. So these women, I would say, it's going to take a while to kick in. I want to see you back in 2 weeks. And I'd see them back in 2 weeks, and I'd say, so how's the medication working? And they go, oh, I stopped it. It wasn't working. And I'm like, well, do you remember the conversation we had? Well, kind of, but it wasn't working. And it's like, it's those kind of barriers. You got to work with people. This may entail more effort than we realized, or that the system pays for. So we just have to be thoughtful about how are we going to work that into that interaction. The history of somebody. Patients new to antidepressants are likely to be at greater risk of discontinuing treatment than patients who have previously been on therapy. Patients who have been on therapy in the past know that it works, know that there's a light at the end of the tunnel, much more likely to say, okay, I know, I'm going to grit my teeth, I'm going to get through this, I will continue to take it. If you're new, if you're a virgin to a medication, it's like, well, it wasn't working. I have a pal who has been struggling with depression, multiple trials of antidepressants, very smart. And he, a month and a half ago, stopped taking his antidepressants. I mean, this is a very smart person who's educated about depression. And he said, I just stopped, it just wasn't working. Well, in the intervening time, this person has become profoundly depressed. And it wasn't actually until last night that I found out that they had chosen to stop their medicine. I said, did you tell your doctor? Well, I kind of hinted at it. He's now facing ECT because he's become so profoundly depressed, but stopped his medicine and didn't tell anyone. And again, very smart person who knows that, and at this point cannot tell that he feels any different than he did 6 weeks ago. Everybody around him knows he's gone to hell in a handbasket. But he can't see it. He can't see the vast difference or the consequences of his non-adherence. So, pretty challenging. The next thing are things that I think it's important that we think about, that it's hard to do because systems of care are often not set up to enhance a therapeutic alliance, simply because when I was at UAB, my Wednesday afternoon med check clinic was populated by 25 appointments. Okay, so within that time, I'm supposed to see the patient, educate the patient, establish a therapeutic alliance, write the prescriptions or send the prescriptions electronically, do the check. I mean, there's massive amounts of EHR work that's required. Now, if I was fortunate, and it's weird that I think about it being fortunate, if I was fortunate, only 16 would show up. So that's about 15 minutes per patient. Not so fortunate for the other 9 9 who were supposed to be there, who didn't show up and then wouldn't get their medicines, et cetera, et cetera. See, we have to be thoughtful about systems of care, and how do we convince insurers that it's good to pay for perhaps longer medication assessments and evaluations. Now at UAB in my clinic, we had it set up. It was just wonderful. We had 4 nurses who staffed the medication clinic, so they would see the patients before, do symptom checklists, they would call the boarding home, they would talk to mama, they would so they could kind of strip away some of that time-consuming stuff. So I was able to see the patients and kind of say, how you doing? But that again gets back to that issue of longevity. I could say, how you doing to Tommy, because I knew Tommy, and I knew Tommy's brother, and I knew Tommy's dog. But if you're a new person, or if you've inherited this person, it takes more than 7 minutes to talk to a patient, elicit information, do that education. So I feel like we're constantly kind of struggling with the man to try and meet the needs of our patients. Okay, therapeutic alliance. Is your clinic welcoming? By that I mean, when they walk into the clinic, are they greeted? Are they treated with respect? Are they kept waiting for an hour and a half? In my clinic until recently, when Pam retired, we had a receptionist who had been there for 37 years. So she knew everybody. And she could pick up the phone and say, Mr. Smith's kind of boiling over the top. I think you need to move it, because we were first come, first serve. You need to move him to the top of the list. But she knew everybody, and she knew everybody's story. And this is a woman who had a high school education, but was one of the better clinicians with whom I've ever worked, because she got people, she welcomed people. She was not particularly, how can I say this, chatty and warm and friendly, but the patients knew that she cared about them, and would go the extra mile and would find what they needed. And so the questions to ask yourself are not just, can we get them in, can we check them in, can we get them seated, can we get them moved, but how we do that, what's the process of doing that? Again, does the patient see the same clinician every time? Do they feel respected? Like every patient that I see, I stand up for it, and I used to shake their hand until swine flu, but then I started bumping elbows with everybody. And I mean, I wash my hands in front of every patient every time, but I bump elbows. But I would stand up, because I think patients need that respect. When I go see my primary care doctor, she stands up and shakes my hand. When I round on the inpatient unit, when a patient comes into the rounding unit, I stand up. And my residents and medical students are like, what are you doing? Well, that's how you show respect to somebody. I mean, and what that take, how many ATPs did that take me to stand up? But it communicates to someone that you respect them as a person, and it's part of that engagement. Are patients living in a stable living situation? I mean, it's hard to take insulin if you live under a bridge. It's hard to keep track of your medicines if you live in the shelters and somebody's stealing your medicine. So you have to take that all into account. How are they going to carry their medicine? How are they going to keep it safe? What's the degree of support or supervision they have? Is mama living at home and she makes sure that he takes his medicine at 10 o'clock every night? Does he live in a homeless shelter where nobody It's not that nobody cares. It's that, if you're working with 120 men, it's hard for you to find the time to make sure that everybody's taking their medication. In discharge planning, it's always amazing to me, not so much with the hospitals. I think the hospitals have gotten very good about making sure somebody has a prescription. I know in our units, if somebody can't afford it, we will, it's called charity, it's not charity care, it's something care, compassionate care. Well, there's a fund that will buy people a month's worth of their medications, not just their psychiatric medications, but all their medications. But then you kind of make sure that there's an appointment afterwards. With Bryce, which is kind of a feeder to the mental health centers, we're under a fiduciary contract with the State Department of Mental Health to see people within 3 days, 3 calendar days, not 3 business days, 3 calendar days. And if we don't see them, if they don't show up, we send somebody out to find them. And that's because the State Department of Mental Health has finally learned that if people don't get hooked into a clinic, they get lost. They get lost, they don't get their medicines. They don't get their medicines, they end up back in the hospital. It's not rocket science, but it took years for that to happen. I wish we had the same thing in place for the Department of Corrections. The Department of Corrections, by a federal decree, is supposed to give 30 days worth of medications, but they sometimes do, sometimes don't, sometimes have follow-up appointments, sometimes don't. All right. What are the consequences of non-adherence? How do you know or suspect that somebody has not been taking their medications or following the treatment plan? Their symptoms continue. Their symptoms get worse. They end up in the hospital, where unfortunately you can be subjected to the trauma of seclusion and restraint. I'm sure you've all seen people get restrained either chemically or physically. It is a very traumatic process for patients, and it can cause triggers in people when they come back to the ER, when they're up on the ward. So people recycling back in, perhaps a consequence of not taking their medicines. Increased frequency of and severity of their illness. But when people stop taking their medicines or take them in a non-adherent fashion, it's not just their symptoms, because I want us to think about patients more globally than just their symptoms. You have to think in terms of how does it affect their life. I mean, when I ask patients what they want, at the end of every time I do an evaluation, I say, what is it that you want and how can I help you get that? Most of the time, it's not, I would like you to get rid of the voices. Most of the time is, I'd like to get my GED. I'd like to have a date on Saturday night. I'd like to have my driver's license in a car. I'd like to have a job. Probably the most heart-wrenching one is, I'd like my mom to be proud of me again. I mean, that just kind of goes, oh God, there are all sorts of disabilities or effects on lives that aren't just solely related to, are you hearing voices, you seeing visions, any thoughts about wanting to hurt yourself or anybody else? I mean, that's kind of our checklist approach, but I think, and as you explain that to patients, they're going to see that you get them. It's not just about, can I get rid of his voices? Because a lot of times, we don't get rid of the voices, but there are other ways we can work with people by getting rid of voices. The other consequence of non-adherence is our patients get sick and maybe don't have the sense to go to the emergency room, but instead they throw a brick through a window. And that starts that long, slippery slope into the criminal justice system, which is where it's really hard for anybody to get into the criminal justice system. It's very hard for somebody who's psychotic or manic and grossly disorganized, prone to violence, and they end up in the criminal justice system where care waxes and wanes. Probably the ultimate consequence of not taking your medicines is suicide and death. 50% of patients with schizophrenia try to kill themselves. So it's not just depression. And of those, 10% succeed or are successful in completing. So it can be subtle consequences or it can be really dramatic consequences. So what do? I can't change if somebody's young, not married, unless they want to marry my daughter. All right, we're working all the points there. And it's very difficult to penetrate poor insight. I mean, it's somebody says, the clouds are talking to me, so I have to wear this cap that's lined with aluminum foil. Well, I don't say, come on, give me a break, get rid of the aluminum foil. There's no such thing as voices from the clouds. That's the best way to disrupt a therapeutic alliance, is to denigrate somebody's delusion. You just don't do it. You can engage in it. You don't have to reinforce it, but it's really hard when you work with somebody who has little or no insight. So there are several practical recommendations. When I talk about generous discharge planning, I'm talking about making sure they have medicines, they have appointments, they have a means by which to pay. That's the third bullet. Minimize financial barriers. Consider generics. Consider patient assistance programs. There are a lot of stores who have a $4 medication list. So we need to be creative. That takes time, but over time you can learn those things and teach your staff to help you in that hunt. Again, encouraging smoking cessation, making those clinics and your patient interactions warm and respectful. Those logistical things I talked about. How can you minimize the number of pills that they take? I've had patients who say, I'll only take 5 pills a day, or I won't take colored pills, I will take white pills. So you have to get creative, but you have to respect that because you want to get them to take their medicines. You need to explain things to the patients, and what can they expect. And the challenge of that is it's time consuming. And you may not just be talking with your patient, you may be talking with a family member. And you have to remember those things of literacy and visual acuity, and all of the things are woven into how we can improve that. You may want to consider long-acting injectables. I've used tons of them. I have some patients who prefer them. I have some patients who refuse them. So you just have to get a sense of, is it going to work? Will they come back for the shot? But there are other ways. How many of you are aware of assertive community treatment? Oh, it's such a wonderful service if you can find the mental health center and the patient lives in the right catchment area, et cetera, et cetera, et cetera. Assertive community treatment is funded actually by Medicaid, and it actually pays really well. And so there are ACT teams at every mental health center here in the state of Alabama. There are 2 full Fidelity ACT teams, which means they are fully staffed and they fully are available 24/7. One of them's at UAB. And what these people do is it's a treatment team that takes care of a specific cadre of people. There are requirements that have to be met to get onto the team, but they are available 24/7, 365 days a year. They will see some patients up to 3 times a day, 7 days a week, to make sure they get their medicine, that they take their medicine. The nurses go out, they'll give them their long-acting injectable under the bridge. So there are services that might be available for patients who are having significant trouble with their adherence and whose recidivism record is such that the State Department of Mental Health and Medicaid go, oh, it makes sense for us to pay a little bit more to reach out to these people. Because there are some people who simply will not come to our clinic. Our clinic at UAB is in the same, it's called the Byrd Building, 920 20th Street South. But it's in the same building, the first 3 floors of the HIV clinic. And they won't come because there's a stigma attached to that, in addition to stigma attached to coming to a mental health center. So the assertive community treatment program has been phenomenal. When we first started it, we were taking people who had been in Bryce for years, or who had been to Bryce 4 times or more, which is very expensive for the state. And our task then was to keep these people out of the hospital, and we've actually done a pretty good job. There's a huge literature on the appropriateness and the effectiveness of ACT teams. It's also, I think, really important to embrace what's called a recovery-oriented, strengths-based, patient-centered treatment planning. I firmly believe that if you are a provider and you don't provide hope to your patients, then you shouldn't be treating those kind of patients. If you can't say, I believe we can get you what you want, Remember that last question, what do you want and how do I help you get there? Because if you don't offer patients hope, they're like, why am I doing this? It's not going to get better. You can't promise me I'm going to get better, and you really can't promise they're going to get better, but what you can say is, I promise I'm going to work with you, and I promise I'm going to be here, and we're going to find something, hopefully, that works. There are other treatments that are available. There is a first episode clinic, actually at UAB and at JBS, which is the Mental Health Authority, that provide things like cognitive remediation, family support, vocational support, cognitive behavioral therapy. So all of this needs to be tied together. I mean, I know this is called mental illness and medication, but if that's how you conceptualize mental illness, you just treat it with medication, then you're missing a whole lot of other stuff that actually might be helpful for your patients. All right, I'm going to just read this from 2003, so it's kind of dated, and it was the New Freedom Commission that was promulgated by the second President Bush. When clients and family members have access to timely, accurate information that promotes learning, self-monitoring, and accountability, and providers develop individualized plans of care in full partnership with clients and families, hope of recovery will be reinforced for every individual, sorry for the typo, giving clients real and meaningful choices and focusing on recovery rather than merely symptom management. Again, it gets to that core issue of linking medications, linking treatment to a recovery trajectory, getting better, not just medication. So that recovery orientation that I'm talking about is how you tie clinical stability to areas of importance of a patient's life. And I'm going to give you a quick example of a patient named Mario who's given me permission to speak about his case. When I first met Mario, young man, burnt bridges with everybody, family, police, church, girlfriend, was smoking 4 blunts a day and drinking 2 cases of beer a day, in addition to not taking his medication. So, I mean, 4 blunts, that's a lot of marijuana. Especially nowadays, that's a lot of marijuana. And what I said to Mario was, you know, I was finding myself doing the mama finger pointing at his nose. Mario, you got to stop the drugs. You got to take your medicine. And he'd go, yeah, I know, Miss Jackie, I know. And it's like, oh, this is not working, because he kept going down and down and down. And so finally, I said, Mario, what do you want? What do you want with your life? And he paused and he said, I'd really like to visit my brother in Florida. And I said, well, what's keeping you from visiting your brother in Florida? I can't afford the bus ticket. And I said, well, maybe if you went from 4 blunts a day to 3 blunts a day, you could save up money. And so he came back in 2 months, and I said, how you doing? He goes, I visited my brother. It worked. I went from 4 to 3 blunts a day. It wasn't too hard to do that, and I was able to go visit him. And I said, well, that's great. You want to visit him again? And he goes, I do. And so this was before I retired in 2016. I worked with Mario for 5 years. By the time I said goodbye to Mario, he totally stopped marijuana, was down to, we had negotiated 2 beers a day on Saturday and Sunday, sober the rest of the day, a week, back with his family, had a girlfriend, had a part-time job. Now, the key to that was I had to think creatively about how to tie recovery to sobriety and taking his medications. I mean, he was grossly psychotic, but that wasn't what was important to him. He wanted to visit his brother. And so when we did that, when we negotiated, and it was always a negotiation, because he would say, I don't want to stop drinking beer. Now, you know, in the past you're taught total sobriety. There's now theories called harm reduction. You reduce it. You reduce the harm that's perpetrated or perpetuated by substance use. And you go, well, okay, I can live with that. And so it was like, oh, Dr. Feldman says I can drink beer. And in essence, I was saying, that's what you need. I respect you as a person. You're in charge. I mean, I'm not there at 10 o'clock at night to see if he takes his medicine. But if he feels like he's been respected and that there's by taking his medicine and cutting back on the beer and stopping the marijuana, he can visit his brother, and now he's got a part-time job and he's got a girlfriend, and Mama's not mad at him anymore. It was working. But the other key to that was 5 years is what it took. This wasn't an overnight success. So it took patience and a relationship where I kind of gave up this matriarchal, you do it, or we're going to discharge you from the clinic, or I don't want to see you for 6 months because it's not worth spending any time with you anyway because you don't trust me anyway. We were able to move beyond that, and he got engaged in his own recovery, and that's what I'm talking about when I talk about shared decision making, is doing that negotiating. I mean, I'll have patients who say, I am not going to do X, Y, and Z. They're telling you. Now, I could still say, well, you gotta. And that might work that day if I'm giving them a Prolixin decanoate shot, but it ain't gonna work in the long run. So I have to figure out what are their symptoms, how's it impacting their functioning, and what do they want. The other thing that's become really important is the use of peer specialists, where you've got somebody who has had that lived experience who can then sit down with the person and say, I know what you're talking about. I've been there. I've been to Bryce 4 times. And there is a cadre. Each mental health center has a peer specialist that are trained specifically by the State Department of Mental Health who can help out with that. So the challenge is that it takes time and a trusting relationship, and I have to give up. I'm a control freak, and it's been a trajectory for me to learn to kind of give that up. I'm not going to talk about motivational interviewing because that is a whole different topic. There are experts across the nation. One person who you might consider bringing in is Michael Flom, who's out of the University of Iowa. But it's a wonderful way that you can talk with patients and get them to think about changing their life. All right, I think I'm pretty near through. All right, so broader issues, because I'm running over. You do want to help patients get established with primary care, because I may just be treating their brain, but if they've got hypertension, diabetes, and asthma, you want to make sure that they've got treatment in place. You want to encourage lifestyle changes. What's their housing like? Are they getting enough sleep? Are they getting enough food? If they don't know where to go get food, you need to find out where they can go get food. Are they having intimate relationships? And if they're having intimate relationships, you want to talk with them about birth control and about prevention of STDs and their substance abuse. This is a political moment. I'm an advocate for expanding Medicaid. We've left billions of dollars on the table that I think we could have utilized. So don't get me going on that. You can work with Medicaid about advocating reducing barriers and access to medications. And I would hope that you would become advocates for diversion from the criminal justice system. If your patients have mental illness and they get engaged in the criminal justice system, there are things called mental health courts and drug courts and now veteran courts that get people diverted from the criminal justice back into treatment that they so desperately need. So with that, I'm going to end, and I know you have another speaker, so I'm going to go to the back of the room if you have any questions that you want to pose to me. But thank you so much for your attention. I appreciate it. Let me get dewired here.
You can bring those over.
Okay. Yeah.
It's 3:30 for the pharmacists who need a preceptor license. If you do not, don't feel obligated if you're good for another year. We do this annually, so you'll still have an opportunity. Between 12:30 and 2:30 will be the vaccination and immunizations.
At least we'll get a lot of static in this.
The preceptor is right now.
Is this the one?
Yeah, this is. And this is going to be your. And they're both on and ready to go.
Thank you. Oh, you're welcome. We really appreciate it.
And this is going to be your live stream.
All right, thank you.
Say we need
Oh, and I'm sorry, there's cookies in the back, for those of you who would like.
Did you let them all leave?
Keep your people well fed.
They,
Yes. Okay.
It's bathroom break time.
You have to be like, and you could take $1,000 and it wouldn't be 50. You have to do this. Yeah. And then you have all these, guys come back.
Okay.
All right.
We're back up and running.
All right. Don't trip. I tripped over those. Should I go ahead and start?
Yeah, whenever you're ready.
Okay. All right, everyone, thank you for having me back for the second talk. I'm going to talk about vaccines from past to present and talk mainly about adult vaccinations. I love children, I have children, but I am not a pediatrician. So I'm really going to be focusing on adults. So here's our outline today. I want to discuss the history of vaccines and really talk about how smallpox was eradicated through concerted efforts across the globe. And then we'll talk about key diseases and the reasons behind vaccination and what you can do for your adult patients. So smallpox is an interesting story, and I love telling it from an epidemiologic standpoint. In order to understand how viruses work, we in epidemiology like to understand what's called a basic reproductive rate. So this is the number of new infections from a single infected person. So something that is how infective is it from one person to the next. So for instance, Ebola you would think would have a high reproductive rate, but it's actually 2. Their reproductive rate is pretty low at 2, so you can infect 2 people. And that's because you have to be in close contact with those people. In smallpox, it is contagious, it is airborne, but it's moderately contagious, so it can infect about 4 people for every 1 person that has the infection. With measles, though, it's extraordinarily high, and this is what we've been dealing with up in New York and in other areas in the country. Measles probably has the highest basic reproductive rate. 1 person can easily infect 30 people, depending on your vaccination status. So this matters a lot to us in terms of who needs a vaccine, how can we develop it. Smallpox is one of these great stories. So in order to understand it, smallpox is a virus, it's a pox virus. It's moderately contagious. It's transmitted through saliva or by direct contact with the lesions on the skin. And people with cough were considered the most infectious people. You can see it like smallpox because it's been so well known and well documented. It has a very clear pathway of disease. So in the first 7 to 17 days, you inhale it and you become infected, but you incubate the virus, and then you get this prodrome right here. And the prodrome typically is 2 to 3 days before you develop a rash. So this is very classic. You get a fever first, and then you develop this erupted rash. So it starts here, 1 to 3 days you start to get some lesions, and then they continue to crop up. And then they're mainly pustules, followed by crusting, and then desquamation. And so they leave these classic pox scars. These people, you can develop antibodies to this and get over it, but it had a high mortality rate associated with it. Everyone is concerned about the differential diagnosis between smallpox and chickenpox, but there are 2 ways to differentiate the 2. And first of all, we're not going to see smallpox here. It's been completely eradicated unless we had a huge bioterrorism attack. But fever, 2 to 4 days before the rash is smallpox. And the appearance of the rash is pox all at the same stage. So they all crop up at the same stage, and they're very slow to develop. Whereas chickenpox, you have a fever at the time of rash. You have pox that kind of crop up in several stages, and it's very rapid. In terms of smallpox, when we realized that smallpox had such a high mortality in the 1700s, there were scientists that were attempting to prevent transmission of smallpox. And so they realized that these pox vesicles had infective material. So in the 1700s, they'd take this material from the vesicles or pustules, or even the scabs from the patients with mild infection, and they would put it onto the skin or into the nose of other patients. That's called variolation. 2 to 3% of these variolated patients would die of smallpox. They would become a source of a new epidemic, or they would develop illnesses from the lymph tissue of these donors, such as tuberculosis and syphilis. So it's really not the best way to prevent an illness, but they were on the right path to understanding, like, how can we prevent this disease? So Edward Jenner is the first person that really recognized how to create a vaccine for smallpox, and this story is great. So he saw that there were milkmaids who had cowpox. So cowpox is kind of like a cousin to smallpox, and so when you would milk a cow, you would get these lesions on your hands, and then you would get scarring from that. So he saw that milkmaids who had cowpox in the past were actually immune to smallpox. And so in 1796, Jenner used this cowpox fluid pustule from a milkmaid, and he inoculated this 8-year-old who was his nephew, which this would not be okay now in any way. So he inoculated his nephew. I don't know why he even agreed to do this. And then he exposed his nephew to smallpox, and it worked. So 6 weeks later, he then variolated a child. So not only did he expose a child to smallpox, then he did that variolation, and he did okay, no reaction. And so then that was proven that he had created a vaccine for smallpox. Luckily, we now have better ways of creating the smallpox vaccine. And so in the early 1950s, many people who were born in the 50s probably had their smallpox vaccine scar. And it was with this bifurcated needle, and it would create this reaction on the skin in order to create scabbing, and then you would be protected from smallpox. What made smallpox become eradicated globally is because the WHO really got behind it. And so in 1967, there were still a fair amount of cases, 23 countries in Africa, 7 in Asia, Brazil and the Americas, and they had 3 key principles to participation in all countries, adaptability of national programs, and ongoing research. And through that, the last human smallpox case was actually in the United Kingdom in 1978. It was unfortunately a virology lab, had very poor safety precautions, had viral airborne transmission in a closed space. It went to a dark room 2 flights away, and a hospital photographer that was in a different room had died. And so because of all of this, the virology director actually committed suicide. So you can see how contagious it is, but that's the last known smallpox case in the United Kingdom. So what makes smallpox so successful? Well, that very low basic reproductive number is very helpful. It's only 4, remember, we talked about 2 for Ebola. Influenza is around 2 to 4. You have herd immunity, which is, we try to not say herd immunity as much anymore because people don't like being referenced as cows, but it's more community immunity. So we all have this immunity that was feasible because low overall coverage. Excellent vaccine, it worked really well, it was very stable. There's no animal reservoir for smallpox, so it was easy to eradicate. There was only 1 serotype, no mutations, very obvious clinical syndrome. You could obviously tell when people had smallpox because of the poxes. Global collaboration, and interestingly, that collaboration occurred during the Cold War, which is a very unique situation. And then finally, we have strong national and international commitment with expertise and money, and a motivated local populace. And so through all of those, we've been able to eradicate smallpox. So smallpox is like the story that we want for all of these other vaccine-preventable illnesses. In order to go further and talk about what we're going to be talking about, I thought it'd be helpful to just take a step back and say, what types of vaccines do we have? So we have our live attenuated vaccines. So that's going to be your measles, mumps, rubella virus, varicella, which is chickenpox. Your influenza nasal spray only is live, and then the rotaviruses, which is what we give to babies. These are passed through multiple cell cultures until they're unable to replicate well in the host, but really can provoke an immune response. So even though it's a live virus, theoretically it should not replicate in your system, but we do avoid using it in immunocompromised individuals as well as pregnant women. An inactivated or killed vaccine is going to be like poliovirus and hepatitis A. Those are heat and chemicals that inactivate it but are still intact for an immune response. Our influenza vaccines, the ones, the shots, those are inactivated viruses. We have toxoid vaccines, so there are some bacteria for which we've created vaccines, and that's going to be your diphtheria and tetanus. And both of those create a very specific toxin, and so this is inactivating the toxin. And then finally, we have something called a subunit and conjugate vaccine. So the subunit means that you have this gene coding of a vaccine protein that's inserted into another virus or cell. And then conjugate is where you take a piece of part of this coat of the bacteria or part of the coat of the virus, and then that's linked to a carrier protein. And because it's linked to this carrier protein, that creates this really powerful immune response. So the conjugate vaccines create the most immune response, almost as good as a live vaccine creates a good immune response as well. Okay. So this is our current CDC guidance, and we're going to go through some of these. But just to read it across so you can see this is all for adults. Everybody needs a flu vaccine every single year. And this is either going to be your live attenuated, so that's a nasal spray, but the live attenuated is only recommended through a certain age, or the inactivated virus right up here. You have your tetanus, which is recommended once every 10 years. You need measles, mumps, rubella virus. Hopefully you've already had your measles, mumps, and rubella. So it's 1 or 2 doses depending on the indication, if born in 1957 or later. You have your varicella virus, which is recommended for a large portion of patients. We'll go through and talk about the zoster recombinant vaccine soon. You have your HPV vaccines that are recommended up to the age of 26. And then we'll talk lastly about these pneumococcal vaccines. This is the same slide, but looking at it this way, you want to look down, going down the columns. So if you have a patient who's pregnant, which one of these are contraindicated? Or if you have an immunocompromised patient, which one of these are contraindicated? So all the ones in red are going to be your live viruses. So those are the ones that are contraindicated. And then there are some that have precautions depending on the type of disease. So diabetes has a precaution in terms of our live influenza virus, mainly because of efficacy. We're always concerned that if we give something, we want to make sure it's as efficacious as it can be. Okay. So since we just talked about smallpox, I thought it'd be important to talk about measles because we are all very concerned about measles lately, and for a good reason. Measles has a very classic syndrome. It's fever plus maculopapular rash, so you have a diffuse rash. It's hard to see in this picture. You get this kind of diffuse rash on your body. It's not like the vesicles that you get with chickenpox. And you get these 3 C's, cough, coryza, conjunctivitis. So cough is understandable. Coryza is this kind of runny nose, runny eyes like this, runny nose, that's what that is, and then conjunctivitis. So you get all of these. You have to have one of the 3 C's in addition to fever and rash. Patients are contagious 4 days before the rash and 4 days after the rash. And that's very important from a health department standpoint in order to do contact tracing. So measles in the United States. We've had measles, it was first noticed in Boston in 1657. That's the first documented US case. In 1861, there was a huge outbreak of measles during the Civil War. There were 21,000 cases and 551 deaths in the Union Army. In 1916, there was another huge outbreak, 12,000 deaths. 75% of these are under the age of 5. Before vaccination, before we were consistently vaccinating, 3 to 4 million Americans were infected annually, 50,000 hospitalization, 1,000 were chronically disabled from encephalitis, and there would be about 400 to 500 deaths a year from that. 50% of children were infected by the age of 6 and 90% by the age of 15. So it was really very common in childhood. After vaccination, we reduced these numbers by 99%. So similar to smallpox, we were very hopeful in doing the same thing and eradicating it. So the measles vaccine was initially created in 1957. And then in 1978, the CDC set goals to eliminate the measles. By 1981, we had an 80% reduction from 1980 because of this active program that we developed. And so every year we were able to consistently bring those numbers down. From 1989 to 1991, we had these sporadic outbreaks. There would be about 55,000 infections and 123 deaths. And a large portion of these would occur in unvaccinated children. But because of concerted efforts in the United States, we're actually able to say that we eliminated it from endemic transmission. That means someone born in the United States transmitting it to someone else born in the United States in the year 2000. Now, we continue to see cases, but a lot of these would be brought in from travel-related cases. So in terms of globally, measles is a very important cause of childhood mortality. 139,000 deaths in 2010. Really, the causes would be diarrhea, pneumonia, and encephalitis. About 1 to 2 in 1,000 would get encephalitis, and about 1 in 1,000 get pneumonia. So it's pretty high numbers. Every case is preventable, which is really a big thing why WHO has pushed for all of this. The Global Measles and Rubella Strategic Plan was created in 2012 with goals to reduce measles deaths by 95%. And they have this 5-pronged approach to achieve and maintain high vaccination rates, which can be very difficult in very poor countries, to do active disease surveillance, maintain outbreak preparedness, so this is the key to understanding those syndromes, communicate and engage public and immunization strategies and ongoing research. So they really wanted to try to mimic what the United States had already done. In terms of our vaccine that we use currently, the one that we have now is the same one from 1968. The one that was originally introduced in 1958 was not thought to be as immunogenic, so there's been this concern that people born in the 1960s may not have received as good of a vaccine as those born after 1968. It's highly immunogenic, so more than 90% receive lifelong immunity after one single dose. But it's less effective if you give it before the age of 12 months. So that's why we have that recommendation to give it at the age of 1 year. It's 95% effective if given between 12 to 15 months. Very great vaccine. Through all of these concerted efforts, you can see that the bars are the number of cases that we had globally. And then the red line is how many WHO estimated in terms of vaccines given. So as we got these numbers down significantly, but we always continued to have some cases, mainly because we weren't at 100% coverage. In the United States, if you look at when this vaccine was licensed, these numbers dropped significantly from between 1960 to 1917, a huge, massive drop. And then we would have these little blips and little outbreaks here, but we've gotten it down significantly lower through 2010. But if you go to 2010 through 2019 and you look at these numbers, they've slowly started to creep back up, with the most being in 2019. And the reason for that is for these major outbreaks that have occurred. So the 2019 outbreak, as of when I checked the CDC on Sunday, from January to August 8th, there have been 1,182 cases. These started mainly in places like New York and in Seattle. So Seattle, it was a mainly unvaccinated community. And then in New York, it was an unvaccinated Orthodox Jewish community. 124 people who have gotten measles this year were hospitalized, so 10% of the cases. 64 have had complications, including pneumonia and encephalitis. So this is very similar to the numbers that we saw in the past. These numbers from 2019 are the highest number of cases we've had this year compared to 1990. So we have kind of taken a step back in terms of our numbers. Majority of cases are among people who are not vaccinated against measles, so a large portion of these were children. And then more than 75% of the cases here were connected to these outbreaks that we talked about. Luckily, Alabama has not had any. Just pointing that out, we're doing great. So what's the reason behind some of these outbreaks that have occurred? Well, you can see here, there have been, and this is a New England Journal article, and this is before this outbreak, religious exemptions have gone up, Non or philosophical exemptions have gone up as well. And these easy states that have easy exemption policies have gone up. So you can see because of that, we have these non-medical exemption rates that are increasing. And I believe in 2006, when that paper was pushed out that autism was associated with measles vaccine, there was a huge concern. It was picked up by a lot of celebrities, which then kind of pushed this idea that the vaccine was connected to that. Since that time, that article has been removed. The person that wrote that article has been found to have had fraud for all the data. So there's been a lot of misinformation, though, that's been carried forward, and it's very hard to bring back trust to the community after something like that happens. So what do we recommend in terms of measles vaccine? So we recommend 2 doses. So children get the first dose at age 12 to 15 months, and then the second one around age 5. And then teenagers, if they've never had it before, with no evidence of immunity, it's as soon as possible or the second dose. Evidence of immunity includes at least a written documentation. So if you've got your old blue card from Alabama, I still have mine, or laboratory evidence of immunity, so we check your measles titers, laboratory confirmation of measles, where you've been proven that you've had measles in the past, or if you're born in the United States before 1957, it's assumed that you probably have been exposed to measles. That's not 100% hard and true rule, but that's how we view it. In the healthcare system, we actually recommend specific testing to do titers for that, unless you can prove your documentation. So we at UAB have had a concerted effort, if we don't have your vaccine recommendations, to get titers for that. Okay, so moving on to varicella zoster or chickenpox. So chickenpox is very similar to measles. It's still very contagious, but not nearly as contagious as measles. It enters through the oral mucosa, so you breathe it in. It's a very airborne virus, so it's a very small virus that you breathe in. And then it replicates in the liver and spleen, and then it disseminates to your skin. You are contagious about 1 to 2 days before your rash develops. If you have never had varicella before and you're a teenager or adult, you have a huge increased risk in getting a pneumonitis associated with that. So kids, you always felt bad. They have a rash. You have a little rash party, which at least that's what I had when I was a kid. But then they're itchy and they have a fever and they kind of feel bad, but then they overall get better. But as adults, it's actually a much more dangerous virus. So what happens after you have the virus? After you have this initial virus, the virus itself establishes latency in your dorsal root ganglion. So in the roots of your nerves. And so it can reactivate on those single nerve roots and cause shingles. It's extraordinarily painful because it's on your nerve. And it tends to occur in elderly patients because you have your waning immunity. And then it normally is this dermatomal pattern. Some immunocompromised individuals may get what looks like chickenpox again because it's all over. But it can be very, very painful if you've not had it before. So what do we have right now to prevent that? We have 2 vaccines available. One's a live virus vaccine, Zostavax. That's been licensed in 2006. It's approved for those over the age of 60. And the recombinant, and then we have this new recombinant vaccine. So it's not a live virus vaccine, it's attenuated vaccine. It was licensed in 2017 and is recommended for those over the age of 50. So what's the data behind these 2 viruses and why choose one over the other? Well, the live virus, the Zostavax, recipients had a 51% reduction in shingles with less severe illness. But as you got older, you had a reduction in your efficacy. So 70% was 50 to 59 age, and it would go down. So by the time you were 70, you had a 30% efficacy with the Zostavax. But at the time, that's all we had. In contrast, the Shingrix, which has just been released, there's 97% efficacy in ages 50 to 59, 60 to 69, 70 to 79. There's really no reduction in efficacy as you get older. So you can see why the CDC has pushed to using Shingrix over the live virus. You can see, however, the recombinant virus is 2 doses versus the 1 dose for the live virus. So they didn't actually remove the live virus, so you still have that option to give that. But I believe a lot of clinicians are focusing more on the two doses, and we want to give it over the age of 50. The other issue is that, this has been approved for those over the age of 50, and so that's how we've been able to get it for more patients. Once again, they do recommend delay in the vaccine in those who are pregnant, and it is contraindicated. The live virus is contraindicated. There is no data for or against the new recombinant virus in immunocompromised patients. We just don't have enough data yet. It's thought to be safe, but we can't be for certain yet. Okay, moving on to HPV. So HPV is human papillomavirus. It is known as an oncogenic virus. So there are a few viruses that can cause cancer. So these normal cells that we have get infected with the virus, and then that virus can transform into these cancerous cells. So what you can see here, this is for cervical cancer. So the virus gets exposed here and goes into the cervical area, and then it infects these basal cells right here. As they become infected, they transform the cells, which then causes the layering to change, and then that's what develops into cervical cancer. HPV takes years and decades to really develop after exposed to HPV, and actually a lot of people exposed to HPV can clear it on their own, but we don't know who's going to clear it versus who's going to continue. It is known, however, that HPV vaccination can prevent 90% of cancers. So the CDC has recently published some data on who has cases, and so you can see the cases in women and the cases in men. So the ones that we've been more concerned about lately are throat cancer, excuse me, as I cough, and cervical cancer for women, of course. But we've also been noticing increasing numbers of anal cancer that are associated with HPV, penile cancer, vaginal cancer. So these all add up to a pretty high burden on our U.S. healthcare system. 20,000 cases in women and about 13,000 cases in men. So the vaccine schedule, we recommend to start talking to these to kids early, and so you want to really start getting either both boys and girls around age 11 to 12. But you can get these ones later on, and then they even recommend it up to the age of 26. However, there was recent data, a recent advisory committee from the CDC, and they had this discussion to recommend it for the ages of 27 to 45. But mainly for those who had not been vaccinated, because as a reminder, the HPV vaccine, they can either cover 9 or 18, or a large portion of these different types of viruses that can cause anal warts as well as cancer. And so you can talk to your patients between the ages of 27 and 45 to see if they want to be vaccinated against HPV. Now, I would say that if it's not in the CDC recommendation or the ACIP committee, I'm pretty sure insurance companies will not allow it, but that's just something that you can talk with your patient about and talk about it with their insurance companies. Okay. Influenza. So influenza is what we call a segmented virus. It has these different virus parts that kind of go together. And when they get near another one, they have a tendency that they can mix and they can change and cause a different type of virus. There are 2 proteins that are on the virus that we look at a lot. There's something called hemagglutinin, which is a glycoprotein, and that binds to the respiratory epithelial cells, and that allows the virus to enter in and cause an infection. The neuraminidase, however, it cleaves the sialic acid, it prevents this virus from clumping, and then releases the mature virus. So this is how we get H1N1, so that's how we get that nomenclature. It's all through those 2 types of glycoproteins. Globally, we see about 1 billion cases a year. 3 to 5 million cases of those are very severe illness, and then about 300,000 to 600,000 or so have these deaths annually. In the United States, we think we see about 20 to 50 million cases a year, 365 hospitalizations, and about 50,000 deaths. Although the new estimate is that the deaths are actually higher than that because we have about 290 to 600,000 estimated deaths because of this concern that after you have a respiratory illness, you are at higher risk for having myocardial infarction. So these numbers are continually moving, but at least we know a pneumonia-related deaths is 50,000, but this may be more. So this comes from FluView. I love FluView because it just shows you exactly how you would expect influenza to look. So on the bottom are the weeks, so every week, and then on the top are the number of positive specimens, and then the typing that is performed. And you can see what you would expect. So let's see, the beginning of, let me see if I can find 2018. So here's 2018, 2019, right around here. So this is going to be like November, December, January, February, March. So that's always the months where we see the most flu cases. Most of these are influenza A, which is the orange and the red, and then the B is going to be your green and yellow. If you look at patients at the rate of influenza-like illness, every year it looks about the same. But last year, or in 2017, 2018, we had this huge number of cases. In case you don't remember, 2 years ago, large portion of cases. The red line is what we had this past year, which is much more like what we normally see. It goes up and then it comes back down. This line right here is the 2009 pandemic flu that we saw. So we had as many cases 2 years ago as we did pandemic flu. And what you can also see associated as the influenza mortality. So 2 years ago, this was our mortality rate. So a large portion of people were very sick and they died from influenza. If you look at pediatric deaths, which is a very huge marker for us, because if you're seeing children die from influenza, in 2017, 2018, it was extremely high, 187 deaths in children. Last year, we actually had a pretty high number as well, 129. So anything that we can do to prevent deaths in children is very important. So how do we make these viruses, these vaccines? So we take, as you know, we have either 3 viruses or 4 viruses that are put into a vaccine. So strain number 1, so this picture is showing you strain number 1, strain number 2. So they inject it into a fertilized chicken egg, which is right there. And then the genes from the flu strains multiply and mix with the genes from the other flu strain. And then they make possible combinations that go in here, and then you continue to grow them. And then you can finally get as many combinations from the flu strains that you want, which then go into your vaccine. Now, for those with an egg allergy, this is not ideal, although the CDC has said that if you have an egg allergy, you can still get this egg virus, but there are egg-free flu vaccines. I can tell you my son has an egg allergy, and every time he gets the vaccine, he breaks out in hives, so it's not fun. But I do continue to give it to him. So unfortunately, this is the best vaccines that we have currently for the viruses. We try to estimate what flu strains go into that flu virus or flu vaccine based on what we're seeing in Australia and other places. And then we put it into a vaccine, but there are some years where we just don't do a good job matching. This is 2014, 2015. It was a terrible year. I mean, overall, these are not that great, right? So this is 40% effective, which is better than nothing. Let me tell you, if you have the vaccine and you get the flu, your symptoms have been shown to be less than, say, people that don't get it. But every now and then, the virus can morph and be slightly different than what we thought it would be, and then you're not being covered by the vaccine. What are the available flu vaccines? So you have what's called a trivalent flu vaccine. So that includes 2 A strain viruses and 1 B strain virus. The quadrivalent flu vaccine includes 2 A's and 2 B's. We do what's called if you are over the age of 65, it's recommended that you get this high dose flu vaccine. That's a trivalent flu vaccine. It's 24% more effective than the standard dose. It's found to have lower readmissions, and so we try to push for those to get the high dose flu. And then the recombinant flu vaccine, which is the quadrivalent flu vaccine, has actually been shown to be slightly higher immunogenic than the live attenuated ones. We're not 100%, but the data is still coming out about that. And then the live attenuated nasal. So last year, the live attenuated nasal vaccine was removed from the CDC guidance. And then there was a huge uproar because they thought that the data that the CDC was looking at was not correct. The CDC thought that it was not good for infants in terms of creating an immune response, and so they had removed it. So now it's recommended for ages 2 to 49, but not recommended for pregnant women, those who are immunocompromised or allergic to aspirin. Okay, so Streptococcus pneumoniae. Streptococcus pneumoniae is a gram-positive bacteria. There are over 90 different types of Streptococcus pneumoniae. It commonly lives in our respiratory tract. It can be isolated from the nasopharynx from anywhere from 5 to 90% of healthy people, just depending on the population. Transmission is really from person-to-person contact or through these respiratory droplets. There are a few clinical syndromes that you can get. So pneumonia, 400,000 hospitalizations annually. 30% of all community-acquired pneumonia is related to Streptococcus. Case fatality rate is anywhere from 5 to 7%. Some of those cases can lead to bacteremia, so you get bacteria in your bloodstream, and that's about 20 to 30% of those pneumonia cases. But there have been about 5,000 cases of bacteremia where someone does not have pneumonia. You can also get meningitis and then acute ear infection. So all three of those together can be, or all of those together can cause a lot of disease in a lot of hospitalized patients. In terms of risk factors, you can have a decreased immune function from diseases, from drugs. If you don't have a spleen, you're at a much higher risk of getting Streptococcus pneumoniae. If you have chronic heart, lung, liver, renal disease, or if you're just older, there are a lot of risk factors that are associated with it. So we have very specific recommendations for our Streptococcus vaccination. In terms of vaccination, it was originally licensed in 1977 for 14 strains. And in fact, one of the researchers at UAB did a lot of the research on the initial vaccines. It expanded to about 23 strains in 1983. That's what we know as Pneumovax, and that's a polysaccharide vaccine. But in 2014, the ACIP recommended that for ages over 65 receive this conjugate vaccine. So recall, the conjugate vaccine creates a stronger immune response, and so that's called pneumococcal 13, which is Prevnar first. So the way to work through it is if you have a vaccine-naive person that's over the age of 65, you want to give the Prevnar, the 13 first, and then you wait 6 to 12 months, and then you give the Pneumovax, which is the 23. For those who were previously received the Pneumovax 23, which we have because this other vaccine wasn't licensed until 2014, then you would want to give that, if it's already been received, you really want to make sure you have over a year before you give the other vaccine because you can have not as good of an immune response. And so then you give the 13. For those who previously received the Pneumovax before the age of 65 and who are now more than 65, so that you want to give them, if this already happened, then you give them the Prevnar, and then you wait that 6 to 12 months again. But really you want to make sure that you have a whole year in between that 23 to the 13. Does that make sense? So 13 before the 23 normally, but if someone's had the 23, then you want to wait a whole year before you give the 13. So this is just showing this right here. So 1 or 2 doses depending on the indication right here. And this is the conjugate vaccine and the polysaccharide vaccine. And then right here you can see the yellow means that it is recommended and for all of these groups here. So asplenia, end-stage renal disease, heart and lung disease. And then once you get over 65, it's recommended for everyone right there. All right. So I went through a whole bunch of vaccines. The only one that I didn't talk about that was for adults is Tdap and pertussis. But I will tell you, we are seeing an increasing number of pertussis cases, so be sure that you tell your patients to be vaccinated once every 10 years. Or if you're pregnant, you get vaccinated every time you're pregnant. So if you had a baby a year ago and then you're pregnant again, you get Tdap like 2 years in a row. Okay, Any questions? Yes, sir.
Vanderbilt a few years ago was recommending for the flu vaccine to take one of them, or, in August or September, and then take like the 3-valent, and then the 4-valent in January. And this gave a better boost, and then it also covered, one more valent.
Yeah, I don't know if I would recommend doing that because there's been a concern that you get this not as good of immune response. So first of all, the new vaccine isn't even released until end of September. So you want to make sure you get the vaccine that's recommended for, 2019. But then secondly, there's been some new data that suggests that if you get 2 vaccines in the same year, you may not have as high of it may be a paradoxical lower immune response. And so I don't think they've really sorted out all of that information yet. That's all observational. It's not randomized controlled trials. And so until then, I would go with what the CDC recommends. But in particular, you want to make sure if you're over the age of 65 to get the higher dose flu vaccine.
Before the vaccine or the viruses were grown in the egg yolk of a fertilized egg, that was developed at Vanderbilt.
Oh, really?
That technique, yes. They did not get the Nobel Prize for it. They should have. Because before that, the only way you could grow viruses was in monkey testicles. And those were rare to have available. But once they were able to grow it in the chick embryo, then that opened virology for the entire world.
Yeah.
All you had to do was have fertilized eggs.
Right. For those at not here, we were talking about monkey testicles, but as a prior way to make the flu vaccine. But yes, I think it's a great technology, and I think as we move into ways to make recombinant vaccines, what we really need is to have a vaccine that's created that covers all of the flu strains. So you want it higher up so that it's got to be something that all the flu types have and carry. And then that way we can have a universal vaccine rather than getting these ones every year.
And the UAB may be involved in that research right now. Vanderbilt's involved in it, and there's about, at least Vanderbilt and 2 other universities are involved in it, and a company in California that does viral work. It's a conglomerate to find a universal vaccine.
Right, exactly. Great. Any other questions? Yes.
Does the CDC have any investigative ideas about sanctuary cities and the possible bringing in of people that might not have been vaccinated, and if so, study that group as opposed to just the groups in Oregon and the Jewish community?
Oh yeah, that's a good question. So the question is, has the CDC looked at sanctuary cities in terms of vaccination and how? I don't know if they have. I know there's a lot of press right now about the flu vaccine and in the migrant camps and those sorts of things, but I think the CDC has tried to steer clear of some of the politics associated with that. But you can't force people to get vaccines. But you can make rules as organizations that in order to work here, you need these vaccines. Or in order to go to the school, you need these vaccines. So as an organization, you can do that. But I can never force a patient to get a vaccine, and nor would I want to. I want people to be on the same side as me, saying like, oh, okay, I get why we need to get that.
Every disease in Central and South America will be brought into the United States.
Right, agreed.
Because the great number of people migrating come from areas that have no medical care at all.
Well, we see, so I think infectious disease doesn't have any borders. So because of things like mosquitoes that can bring in a lot of pathogens like Zika virus or chikungunya, it's not necessarily person specific. It's a lot of the ways that we travel now and how we interact with people. We're gonna continue to see new and emerging viruses and hopefully have vaccines to be able to prevent them. All right, thank you so much. Okay.
got a,
Don Holyfield, good to see you.
and I've got a flash drive. Hey, that's
Hey,
great talk.
thank you. Rachel Lee.
Yeah, it's good to see you.
Yeah, it's good to see you.
Rose, where you ready to be?
Let me get Kathy.
Oh, really? Yeah, if you ever, it's on American Innovations about four-part series. Okay. I mean, it was great. It's a really interesting.
They're going right into it.
Yeah, okay, I'll look into that. Thank you so much.
Yeah, it's just a little. This is the laser. Is there a microphone?
Yeah, come over here. I've got two of them over here. So this one's for your live stream. It's
Okay.
already on. You don't do anything with it. Just pop that in your pocket.
Okay.
This other one's just for the overhead so the people in the back can hear you. You can just drop it in your pocket. It'll be fine.
Okay.
I'll go ahead and turn it on since we're getting ready to
Okay.
and crank it up.
And that one goes in the other pocket.
Yeah.
And then the laser is, there we go. Okay.
And you're on the overhead. So whenever you get ready.
Okay. Oh,
Okay, you're a shift position. So you work for Carnival too?
we've got, I am the last speaker, and I know y'all don't want to stay late this afternoon, so I'm,
You were in the Army.
I need you to kind of hang right back. Yeah.
oh, stay right here. Okay. All right. No problem.
Wait, stand over here. So if you move over, you'll go behind.
Gotcha.
I don't want you to get
Gotcha.
lost.
My name is Carly, well, my name is Carly Brown. On Facebook, it's Carly Brown. I'm tired of patients friending me. You're like so it's for a little different horse.
I'll just go ahead and get started since we're a couple minutes early, but I know nobody minds getting out early. If y'all don't mind, I'll go ahead and get started. For those I haven't met before, my name is Peter Nagy. I'm one of the pain docs at UAB. I'm the interim division director of pain. I practice both in the ORs, in the outpatient pain clinic, and on the inpatient pain service. And I don't have any real conflict of interest or anything except for getting the day off today, which I'm very glad for. You guys have all heard, everybody's heard it, and probably is even tired of hearing about the opioid crisis, so I won't go into great detail about where we are now, but certainly just a quick summary. 4.5% of all the world's opioids are used in the United States, and depending on what numbers you're looking at, 70 to 120 people die each day from opioid overdose. But what I will say that I think is important and relevant is that we as healthcare providers in all different specialties are in a position to make a difference in this crisis. And that's something that I think that we should all recognize. The first thing that we have to do is really take responsibility, taking ownership of the problem and our roles in it. There's a lot of blame to go around. This is an article that was in the New Yorker about the Purdue, the family that started Purdue, the Sackler family, who gets a lot of credit for starting the opioid crisis with their aggressive marketing tactics for OxyContin. And I definitely think that there's blame to go around there. It's a really interesting article just about the background of that company. A lot of misinformation that was propagated around the 90s as well. Certainly the pain education that was sponsored by pharmaceutical companies that was emphasizing the safety and efficacy of opioids. And there's you can see there's even the state, the Federation of State Medical Boards model policy was sponsored by some of the pharmaceutical companies, which is remarkable. This is a really interesting, if you haven't seen this already, this looks at some of the literature that was propagated back in through the 90s. You can look at how often, this is a case report here. This is the entirety, that's the wrong button. This is the entirety of, it's a letter to the editor that was published in the New England Journal of Medicine, and you can see how many times it was referenced from the 80s and beyond, hundreds of times. And it's a letter to the editor that just said in 11,000 cases of hospital admissions, they only saw 4 cases of addiction. So they made the conclusion that addiction is very rare in patients that use opioids. And down below, this other article here, this is a case series, 38 cases. Most of these patients were on very low doses of opioids. And Russell Portnoy there concluded that opioid maintenance therapy can be very safe for patients that have non-malignant pain and no history of drug abuse. And again, referenced hundreds of times. So some of this, very really poorly done studies were referenced hundreds of times to support that. But it's not just the marketing. There's certainly other factors that led to us getting to this opioid epidemic. Some of the patient satisfaction and the production pressures that we see, both to make sure that our patients are satisfied. There's also some commercial and certainly some the reimbursement that comes from third-party payers related to the patient satisfaction. And this is a quote here: once economic incentives or penalties are added to stimulate improvements, we must ask whether the stimulus has an unintended trickle-down effect on prescribing behavior. So other factors are involved. This was a study looking specifically at, published in JAMA in 2012, and it was looking specifically at some of the other factors that can influence prescribing. There's pressures on clinicians to maximize throughput. You can see there's also patient expectations. You go to the doctor, you expect to get a prescription when you leave, and pain is the most common reason that patients go see their providers. Increased pressure on production, again, to get quality, get good scores on your quality metrics and patient satisfaction targets all contribute. And as a pain doc and any provider knows, it takes 30 seconds to write a prescription for Norco, but it takes 30 minutes not to write a prescription. So that's certainly some of the pressures that we're facing. And Alabama has the biggest problem in the country. There's many things that we're number one at and take pride at, mostly sports related, but in this case, we are number one with the highest prescribing rate in the nation. And even though we've come down some, everybody has come down, and you can see that at our peak, we were prescribing 143 prescriptions per 100 patients, and that's come down to 107, but we're still almost double the U.S. average rate. And if you think about it, the U.S. is the highest prescribing nation in the country by far, and Alabama is the highest prescribing in our state. So really, we're the highest prescribing, our state, highest prescribing in the world. So you can get even more granular with this data, but it is concerning when you think about it. But the CDC puts this data out there about prescribing practices, about opioids, and you can see within our state where the pockets are. The darker red here are the highest prescribing counties in our state, and you can even get more granular information when you go to this online tool and enter providers in here, and you can look at this very granular provider level data. So if there's any, this is all publicly available, just going to this website, you can look up prescribing patterns. CMS also contracts out some of this to third parties to look at prescribing patterns, to pick up outliers in opioid prescribing. And you can get these, you'll get these, if you're an outlier, you'll get these mailed to your office. And the PDMP does a really good job of monitoring, and this is something that every provider will get every quarter in there, just as an email attachment, and it also looks at your opioid prescribing. It's very specific and broken down into categories of MMEs, how long you're prescribing for each one of your prescriptions. Are they less than 7 days? Are they between 7 and 28 days or beyond? And those volumes. And then it also looks at benzodiazepine and other sedative prescriptions, combination prescriptions. So if you're combining benzos and opioids, and it's how many of these are of yours, or how many of if you and another prescriber are combining. So I'm writing an opioid, someone else is writing a benzo. So it flags all those, and it's really very useful information. Lastly, there's also the watchdog groups that are out there that are putting this information out. This is on ProPublica, and you can go in there under the prescriber checkup and look at specific providers and how they are faring both in their communities or how they compare in their state and nationally. And you can look at industry, if they're getting how much industry money these providers are getting, and also how much they're prescribing, whether it's generics or specific name brands, and those costs associated with it. And it'll also look at, and you can see here, we can look at trends, and if you look at the state of Alabama overall, the #1 prescription that we prescribe in our state here is hydrocodone. Significantly higher than the #2 prescription of omeprazole, and then we get into the blood pressure medication. So, and you can see here our top prescribers in the state. It'll also list them, and these two guys here were the top when I looked at this last. They were also number 1 and 3 nationally for prescribing hydrocodone. So. That's certainly a list that you don't want to be at the top of, or you'll end up at the top of a headline in a newspaper, like many providers that we'll see in the news pop up because of really being outliers doing this, whether specifically for profit. Mostly it is specifically pill mills, but not always. This is a case that I saw that was a doctor, and it looks pretty bad, prescribed 3,600 pills, but if you look at it, this was 3,600 pills over 4 years. So that's, if you divide it up, it's 2.4 pills per day, less than 50 OMEs, which is really not a high dose in particular. But this doctor was also prescribing a combination. It was oxycodone plus benzodiazepines. And so in the lawsuit, she's accused of failing to properly recognize and treat addiction. The clinic where she was working was also accused of, and they were also named in the lawsuit, as failing to properly train and supervise the employees. The pharmacy that they used, that the patient used, was also accused in this lawsuit. All 3 pharmacies, so it was more than one, and it was that the defendants, all of them, negligently, wantonly, recklessly, and/or willfully caused the patient's death by prescribing or filling these prescriptions. So certainly there's a lot of blame to go around, and there's plenty of lawsuits. Jefferson County has joined into the lawsuits against the opioid suppliers. Kentucky, as a state, is suing Walgreens for their alleged roles. And then this is an interesting podcast looking at whether hospitals should be held accountable for opioid addiction in their patients. So certainly there's a lot of, because there's such a crisis, everybody's looking at whose fault is it, how can we who should be blamed. So there's plenty of blame to go around. The good thing is the CDC guidelines are out there to let us know what's the right thing to do, what are the right ways to practice. And the CDC guidelines came out as recommendations that are voluntary. They're not prescriptive standards, and it was for primary care physicians, not for pain specialists. But I would contend that really the CDC guidelines are applicable across the board, and with a few exceptions, all opioid prescribing, you can say really should follow these guidelines. Legally, a medical expert witness, a medical licensing board, judges, and courts of law can all interpret these guidelines as the standard of care, what a reasonably prudent practitioner would do in the same circumstances. Now, all that said, these came out 2 years ago, and there's been a lot of pushback. This was just recently published in the New England Journal, kind of a mea culpa to some degree about the unintended consequences of these guidelines. So they do put some exceptions out there, and they say this is not intended for populations outside of the guideline scope. So the cancer patients, acute sickle cell crisis, and post-surgical pain, but we'll get into the post-surgical pain, and I don't necessarily think that should be an exception. It also does not support hard limits or cutting off of opioids. So avoid it. specifically says avoid increasing doses over 90 or carefully justify those decisions. It does not support abruptly tapering or sudden discontinuation of opioids, which of course can result in opioid withdrawal and pretty significant psychological distress. And it does not apply to dosage recommendations for patients receiving MAT for opioid use disorder. But just about everywhere else, these guidelines do apply. And I'm going to go through some of them, or I'll go through all of them and some of the background of why I think they're important and where they come from. So it's broken down to 3 categories: when to initiate, the opioid selection and dosage, and then the risks and harms. First one, very simple. Opioids are not the first line. It may seem like a no-brainer, but many times, in particular after surgery, we still use opioids as the first line. So we should always be thinking about using non-opioid alternatives, acetaminophen, non-steroidal, sometimes gabapentin, and some other medications get a little bit more complicated, but certainly thinking of other medications and not just going straight to the opioids as a first line. Establishing goals for pain and function is also important, and the recommendations, certainly in the ambulatory setting, are using something, and this is a very simple scale. It looks at pain scores, enjoyment of life, and then general activity. So this is a 3 question, not going to slow you down in clinic and in any other setting, just to look at some other function so you're not just looking at a pain score by itself. And then discussing the risks and benefits of opioids is really important. This is our old agreement that we were using for years, that we had patients sign in our clinic. It's an opioid, we called them the opioid contracts then, and it says down here that opioids, that the risk of addiction is extremely rare. And these contracts back originally were just so patients wouldn't call after hours and things. But really, the risk-benefit conversation is different now. I think you have to talk to patients about the risks, in particular if they're on long-term, because as you'll see here, the risks are pretty significant. This is a study published in 2014, and it because of the background of providers in the 90s, we're all told that there's very little chance of addiction. They looked at that data, and they looked at 500,000 cases of individuals that had a new non-cancer pain diagnosis and no prior opioid use or opioid use disorder diagnosis in the prior 6 months to this study. And what they found was that a single prescription for an opioid will triple the patient's risk of an opioid use disorder. Chronic low-dose therapy increased their risk of an opioid use disorder by 15%, and chronic high-dose therapy was 120. They're 122 times more likely to develop an opioid use disorder, which is addiction. That's just the new DSM-5 term for addiction. So certainly, addiction is not rare, and the longer you're on chronic opioids, the more likely or the higher risk you will be for developing a problem. So number 4, prescribe short durations for acute pain. So if you have to write opioids and there's no other alternatives, then make sure you're writing short durations, because long-term opioid use, of course, often begins with short-term or with acute pain treatment. 3 days or less will most often be sufficient. Greater than 7 days will rarely be indicated or needed. And this is a study from the CDC looking at the risk of or the likelihood of patients continuing to be on opioids at 1 year. And you can see here, this is the number of days, I'll try to stay in the camera here, the number of days of the prescription and the likelihood of them being on opioids after 1 year. And so this is the 1 year, and this is the 3-year likelihood. So you can see there's a direct correlation. The longer the initial prescription is, the more likely patients will be on, or they could be on them a year from now. This is a study, that was all patients. This is a study looking at surgical patients, and specifically low-risk surgeries. It's published in Archives of Internal Medicine in 2012. And these are patients did not have prior analgesics. 390,000 patients. These are all Medicare patients, but there are other studies we won't get into that looked at younger patients, major surgeries, minor surgeries, but these are all minor surgeries that had a short stay. And these patients, what they looked at was the likelihood of these patients being on opioids after 1 year. And what they found here was that, here, I think that's, what they found here was that 7.7% of patients that were opioid naive that got a prescription after surgery were still taking opioids after 1 year. And that's 44% higher than their matched cohorts that did not get post-op opioids. And again, this is just one study. There's several more I've got in a different talk that goes into different populations and other risk factors. But suffice it to say that opioids after low-risk surgery is associated with low risk. And it's not that these patients had more pain. They're getting prescriptions regardless. This is a study looking at the correlation between 24-hour pre-discharge opioid use and the amount of opioids they were discharged with. So patients, and you can see here, this big blob here in the center, this is the amount of opioids they used in the 24 hours beforehand, and this is what they were discharged with. And as you can see, there's really no correlation in here. And what's even more surprising is that these patients here had 0 opioids for 24 hours prior to that, and this is logarithmic, so they were still getting significant opioids on discharge. So it's not necessarily, it's certainly not related that they are having more pain, thus they're getting more opioids on discharge. Matter of fact, we have been in the habit, our medical culture is that everybody gets opioids regardless, and this is another article that I thought was really interesting. ERAS protocols are everywhere now. I know here at St. Vincent's East, y'all are using the ERAS protocols. This is a really nice study looking at a well-done ERAS protocol. They have all the things that you want in here, the post-op nausea vomiting prophylaxis, the Celebrex and multimodals pre-op, regional anesthesia is when indicated is being utilized, and all the components of a good ERAS protocol. And when they implemented it, you can see here the in-hospital opioid usage dropped substantially. It dropped from 16 milligrams down to 4.8 milligrams. But what didn't change at all was the discharge prescribing. These same patients were getting the same prescriptions that they were getting beforehand, even if they were no pre-op opioids, low discharge pain scores, and low MME consumption. So 72% of them still went home with opioids. So that's something that just hasn't been linked. And the reason why it's a problem, and as probably everyone knows, that there is a direct link between using the availability of opioids and the drug addiction that ensues. So 86% of urban drug users started off using pain pills and prescription medications, which they got from either personal prescriptions or family and friends. And so what happens, those leftover medications, and this is part of another study that was also really interesting and looking at prescription opioid misuse as kind of in an epidemic framework. But what happens is the susceptible individuals here, when there's access through leftover medications in medicine cabinets, there's initiation, and once there is an initiation and people start using these medications just for recreationally, there's this positive feedback loop, which eventually leads to, once you lose the access to those easy to find medications, you end up paying for the medications, and once you pay for the medications, that progression to tampering with them, crushing them, or buying something that's cheaper than the prescription opioids like heroin and fentanyl, then there's that you go down that path, and so it's a scary thing to think about. So certainly there is risk associated with writing larger prescriptions on discharge, and even if they are unused, there's a risk to the community. So I will say, even though the CDC backed off their recommendation about short-term opioids, or that their guidelines don't apply to surgery patients, I think they should be applied. There are very rare cases where patients will need more than that. Using immediate release opioids when you're starting it, and that's certainly something that seems intuitive, but really there's no evidence that in any setting that the long actings are better than the shorter acting. So we haven't found that they are safer, they're not more efficacious, there's not fewer there's not fewer side effects, and you can see your pain function, they're the same. There's no evidence that use of them will reduce the likelihood of misuse or abuse. So again, that's just, there are some preferences or sometimes when it may be useful to use long-actings, but so far there's no evidence that they are better. Using the lowest effective dose when possible, and again, these are the cutoff limits that we hear a lot about, the 50 and the 90 MMEs. And having hard cutoffs is very controversial, and that's what you'll hear a lot of people, or a lot of advocates on both sides are arguing about. But this comes from data that is related to opioid deaths, and there's several papers on this. But as you can see here, when you start increasing the dose, certainly over 200, the risk of opioid-related death is higher, significantly higher. When you're on 100 to 199, it's still substantially increased, and only when you get down below 50 does it get closer to baseline. So there's risk associated with it. The higher doses that you get to, reevaluating frequently, making sure that you're checking at least every 3 months, making sure that there's some improvement, and again, checking frequently and monitoring patients frequently. This is another graph from that same article looking at the number of refills. So the probability of patients being on these medications for a year or 3 years is also directly related to the number of refills. So the longer that you keep patients on them, the more likely they're going to stay on these medications. So strategies to mitigate risk are going to be really important. Providing naloxone is one of those things, and naloxone is certainly underutilized, in that there's been a lot of efforts to make sure that that's available, whether it's through the emergency departments and other places. But there's many risk factors that can increase people's risk of overdose with these medications. Some of them are medical. Some of them, have to do with behavioral. If you've had a history of overdose in the past, substance use disorders, and then other medical comorbidities, sleep apnea, renal failure. Those are all going to be, and of course, concurrent benzodiazepine use. And this is a risk tool that can be used in an ambulatory setting, and there's other screening tools as well, looking at some of the other risk factors, whether it's prior history or family history of alcohol abuse, drug abuse. The recommendations about checking the PDMPs, of course, is going to be critically important. Reviewing it when starting opioid therapy, and at least every 3 months for chronic opioid prescriptions, and using other risk mitigation tools like drug testing to at least annually, but depending on dose and other risk factors, maybe even more frequently. Avoiding concurrent benzodiazepine and opioid use, and this again is a really tough one in an ambulatory setting, because the benzodiazepines are everywhere, and some of those that are also at risk, some of the Z drugs, Ambien and some of the sleep aids, can also be tricky in this regard. But where this came from, again, there's been more than just this study, but this is certainly one that was in our veteran population. That was published in the British Medical Journal in 2015. They looked back at patients who had overdosed, so to veterans who had died from a drug overdose, compared them to a random sample of other veterans that received opioid analgesics, and what they found was that almost 50% of the deaths occurred when they were prescribed both benzodiazepines and an opioid. So there's certainly a risk of that association. The risk of death was 2.3 times higher with a history of benzo use, and 3.8 times higher with a current prescription. So, and the dose, you can see here, the higher the dose, the higher the risk association. And the last recommendation from the CDC, number 12, is to offer opioid use disorder treatment. And certainly there's a referral to counseling centers and 12-step recovery, and then MAT is certainly a component as well. So that's kind of the overview and some of the specific guidelines. And how do we get there? The last thing is really trying to work together, interdisciplinary partnerships, really working in all aspects. And that's what opioid stewardship is. And most everyone is familiar with the antibiotic stewardship that that many hospitals have implemented years ago. Well, opioid stewardship is following that same model, and it's really a premise that healthcare systems, clinicians, pharmacists, and patients must take a shared approach to the problem and recognize that the use of opioids has harm and look for non-opioid alternatives whenever possible. So at UAB, what we'd pushed for a couple of years, we finally established a formal opioid stewardship this past January, and it's structured under the CMO's office. With we have a pharmacist, full-time pharmacist, and a full-time project manager, and of course the IT folks are really critical. But a lot of people are participating. We have monthly meetings and look at trying to advance projects. And some of the things that we started with is education, patient education, and provider education is really important. So just brochures that patients that are coming in for surgery in specific, but other encounters as well, making sure they're aware of the risk associated and some of the other alternatives. And we have a website with resources for providers. But you don't have to be at UAB. A lot of these things are available through our state. The Alabama Department of Mental Health has a really great website with a lot of useful resources and information that's available, toolkits and videos as well. From an EMR standpoint, I think that's really important. We just set up this dashboard, which we haven't started giving feedback. We're just right now just looking and making sure it's accurate. But we're looking at prescriptions that are over 7 days, co-prescribing of benzos and opioids, prescriptions for or opioid usage for pain scores less than 4, so using opioids as a first line. Those are things that we're looking at, and many times it's that's triggered us to revise order sets so that we have lower default settings, or we have non-opioid options that are set up, and we're implementing the e-prescriptions across the board, and hopefully we'll have everybody using only e-prescriptions by the end of the year. We have opioid calculators and some high-risk alerts. But again, that's what we're doing. But without even having to use our EMR system, the Alabama PDMP is a great resource for a lot of these same risk tools and to give us some feedback and real-time information about what patients are, what risk factors and what patients are using. And you can see here that the new NARC-X score, if you look into it, every patient now not only has a list of the providers and the prescriptions that they're getting and how they're overlapping. You also get a NARC-X score, which will look at some other predictors and look at the risk factors. And so how that's used, that is something that can go in the EMR, by the way. The NARC-X score, you can't like copy and paste the actual prescriptions and who the providers and but you can use the NARC-X score for decision making and put that in their EMR. So ultimately, I mean, this is all good practice, but it's even more than that. It's actually mandated. Much of these suggestions have already become things that are mandated by our state law. And if you look at, Alabama was fairly progressive on this back in 2014 with all the rise of the pill mills and many of the problems that were becoming apparent. They established this rule where the highest prescribers had to register as pain physicians. It had to be a physician with that specialty. It couldn't be like an outside attorney from out of state who'd set up an LLC and established a pill mill. And I think a lot of that was going on. So they really were cracking down on some of the worst offenders, but it also started looking at starting at the top with the outliers and how can you identify the big problems, but as a corollary to that, some of the details of what's required. So you have to have, if you're prescribing opioids, you have to have a documentation of a legitimate medical diagnosis. You have to demonstrate that you have a plan to improve their function, not just their pain, that you're using non-opioid alternatives and that they are being considered, and then the informed consent. Certainly a drug screening and a refill policy, those are all required periodic review. And also in 2017, they added another layer that there are specific requirements for these risk mitigation tools for either, you don't have to use all of these, but some component of drug screening, PDMP checks, that pill counts, these things must be included in your practice plan, and they got very specific about how often you check the PDMP if the patients are on more than than 30 MMEs, it must be checked at least twice a year. And if it's over at 90, then it's every time the prescription is written, it needs to be checked. And then there's some opioid-specific CMEs, 2 per year that are required, and this hour certainly counts. Just last September, they added another amendment to that, and that's that physicians reconsider the co-prescribing of benzodiazepines and opioids. That's becoming a bigger problem in our state. So those patients that have both prescriptions, that's something that a discussion needs to be had, and looking at options of deprescribing one of those 2 medications is important. It's not just the Alabama State Board. Of course, we see this in the news a lot of it, and a lot of folks here have had to deal with this. The pharmacies are also getting on board. They're looking at ways to reduce your opioid prescriptions. So CVS, as for an acute pain prescription, they're limiting it at 7 days. Walmart's the same way. Medicaid has limited their prescriptions, and more recently, Medicaid actually set a hard limit, and it's pretty high still. It's 250, but they have set a hard limit, which has again been pretty controversial because of some of the exceptions that we talked about earlier. This was a bill that passed in a rare, had rare bipartisan support. It passed in the federal government. Both the House and Senate passed this. It's called the Support Act, and it's looking at nationally how this problem can be addressed. And one of the things that there's been a lot of finger pointing about the patient satisfaction questionnaires contributing to are overprescribing, and so those will be removed as of October of 19. Those will no longer be part of any of the patient satisfaction queries. They're also looking at CMS's policy for certain non-opioid pain management treatments, because that's certainly when you can't get reimbursed for other medications that are non-opioids or other interventions, then that can limit care. But this act will also establish a technical expert panel. So I think we'll see much more to come. This is going to review all the quality measures related to opioids and opioid use disorder. So it'll start reviewing, first of all, they'll review the existing measures related to opioids, and they'll make recommendations regarding new measures, and for those to be included in the value-based payments. In particular, they mentioned best practices for pain management in surgical settings and pain management protocols that will limit the use of opioids in the perioperative setting. So we're going to see more of that to come. And the reason for that, this was an interesting article that was published out of the Health Affairs blog, and this followed a summit of healthcare leaders where they came out with that they were alarmed at the rate of postoperative opioid dependence relative to other surgical complications. As we said, depending on which studies you're looking at, their rates anywhere from 5 to 7% of patients after surgery are still taking opioids a year later. Well, surgical site infections, which have gotten so much attention, the rate's down to 1.9. So if you look at 5, 6, 7% of opioid dependence, then that's certainly a big problem that should be addressed. And depending on how you look at it, persistent opioid use following surgery could be considered a patient safety concern that meets CMS criteria for a hospital-acquired condition. It arises during a hospitalization. It's a high cost and high volume condition, and it could have been reasonably prevented with the application of evidence-based practices. So I think we're going to see more on this to come. Lastly, the Support Act included Medicare coverage for MAT, or medication-assisted therapy or treatment. It'll increase the number of waivered providers by authorizing nurse practitioners, midwives, CRNAs to prescribe MATs, and it supports the development of curriculum that will help all practitioners get their waiver. And what I hope is that we don't end up with a new problem with the Suboxone clinics and buprenorphine becoming, now it is already one of the most diverted drugs out there. So fortunately, our state has been pretty aggressive in identifying this as an emerging problem. And just a couple of weeks ago, we passed this state bill 423 to establish some guidelines on the use of buprenorphine. So there's more of that to come. That will be enacted in January, but they're getting a group together to start setting some specific guidelines about appropriate doses, co-prescribing of Suboxone with other medications, and some minimum requirements for counseling and behavioral therapy, and gets into other details. That is the end, and I'm a little ahead of schedule because I always talk fast. Is there any questions?
I wonder, we used to think of when the Joint Commission said it was sixth sign, then we used PCA pumps and started them in infusion, get ahead of the pain, et cetera, et cetera, et cetera. Take your academic, information that you just told me, and put it into a clinical setting. We don't use acetaminophen IV anymore, and so preemptively, do you start something before surgery and then continue with some other medication after surgery? We do a lot of orthopedics here, so there's a lot of pain associated with that. How do you go about transitioning and knowing what process to go through?
Absolutely, and there's opioids are still very useful in an acute setting. I think there's no doubting that they're efficacious. The main take home is that it shouldn't be the only thing we're using, and it shouldn't be going home on pills is I think where some of the biggest problems come about. So trying to minimize how much you're using intra-op and in the perioperative setting and in an acute phase is really important. There are many ways to do that. First of all, you start with setting expectations. I think with patients, letting them know it. We used to say, pain the patients have a right to pain control, and as a fifth vital sign, we should always aggressively treat it. And I think the reality is there's risk associated with aggressively treating it. There's problems associated. So pain, just recognizing that some pain is inevitable. That there are things that can't be avoided. So I think setting expectations that yes, you're having surgery, it's going to hurt a little bit. We'll do what we can, but we want to make sure we're being safe. So patient expectations, multimodals. There's other things that can be done. Gabapentin, Celebrex, some of those preoperatively can help. Regional blocks for orthopedics are an excellent way to do it. Whether it's a single shot block or a nerve catheter that's placed, can be really helpful. In particular in that first 24-hour time frame. There's a few things that anesthesiologists can do intraoperatively to try to reduce that, but after a knee replacement surgery or other major surgeries, a lot of times you will need some opioids in that first interval, but try to minimize that, and then in particular getting patients off as soon as possible, trying to we've talked about, we haven't done it, but we've talked about putting timeouts on the 24-hour limit on these PCAs so that orders have to be renewed and they're not just left on PCAs for days upon end. When you get past those first 2 or 3 days, decreasing. Everybody used to go home with 60 and 90 pills and making sure that we're catering that, individualizing that for the type of surgery and that specific patient. If they didn't use any opioids, then they should go home on less. And there's a really interesting paper and a theory about the prescription opioids, and it's demonstrated that if you give patients more pills, they take more. But if you give patients less pills, they end up taking less. Yeah, it's just adjustment, and it's actually from it's from like food. it has to do with portions of food, and there's a psychology, I think it's called adjusting. I can't remember exactly the name of but there is a anchoring and adjusting principle behind that. So if you give less, people take less, and it's not necessarily that they're afraid to run out. Your expectations are set a little bit differently, and the patient satisfaction scores were just as good when they went home with less pills. So there's other things that can be done, but I don't mean to say that opioids should never be used. That's certainly not accurate, and opioids can be very helpful in those first few days, but we really want to try to get folks off of them as soon as possible.
I asked this question earlier, and I keep asking some various responses. What percentage do you perceive of patients are subject to opioid abuse? And I guess I'm asking what percentage of people have a euphoric effect other than others that either have no effect or negative side effect?
It's a really challenging question, and addiction and the risk factors that go along with that that's even it's certainly beyond my scope of expertise. A lot of people have tried to look at what factors are that contribute to long-term addiction. We know some of them are, if there's a risk, or excuse me, if there's a family history of addiction or alcohol abuse, if there's in women, if there's adolescent sexual abuse, there's a higher likelihood of addiction. There's several other any kind of mental health disorders that like depression, anxiety, other things. There's associations there. What makes one person versus another person, you hear stories and there's enough anecdotes that the dopamine rush, some people when they take the medications, they know they get the euphoria, and other people don't. It makes them tired and nauseous and they don't want to take them. And it's very hard to predict ahead of time who those people are that are going to respond. But I think that we definitely know the longer that you keep patients on opioids, the more likely they will continue. And there is a natural upregulation. If you keep exposing your body to these medications, you'll upregulate, and when you try to stop taking them, you will feel worse. And we know of that association. So that's the one, I think that's almost the low-hanging fruit, is how can we prevent this in the acute setting, prevent patients from the long-term consequences. Now, patients that do have addiction, it becomes a really challenging problem about what resources we have, when to use the Suboxone and the MAT, and what components of therapy and other things are going to be important to improve their outcomes. What other questions? All right. Well, got out a few minutes early. So. All right.